Okay, perfect. Yes, let me know. I'll get started.
Okay,
Okay.
let's start the webinar. Hello everybody, dear colleagues, professors and students. Welcome to the webinar. First of all, I want to introduce our valued, respected colleague, Dr. Iqbal Hassan. He is the Director of Emergency Clinic and Assistant Professor of Oral Medicine at East Carolina University School of Dental Medicine, United States. He has been an invited speaker at different levels. Nationally, he plays the role of mentor for American Academy of Oral Medicine for students, residents, and dentists, and planning a career of oral medicine. And he also for oral medicine, and he also the graduate award committee of AAOM. Dr. Hassan, thank you very much. Thank you very much for accepting our invitation to talk about dental clearance for cancer patients. If you are ready, let's start. The stage is yours. Thank you very much.
Thank you so much for the invite and thank you for the kind introduction. So
Yeah.
I'll start about dental clearance patient, especially cancer patients. We see more and more of these cases. And normally when we think about dental clearance for cancer, we think about patients with just head and neck cancer. But we can get clearance requests for cancers for other reasons too. Okay. So the purpose would be to discuss what types of cases would be the purpose of this is to share the information, how to move forward with the discussion with clearance and types of clearances that we get requests for, the complications and challenges for dentists, training and understanding and obligations and limitations as well as responsibilities. Is it same for all patients? These are the questions we should be asking ourselves. And it's not. In short, it's not. Every patient is different. When I say every patient is different, it's in multiple ways, more ways than one. One is we could have a patient who could be going to the dentist every 6 months, following up regularly, getting their cleanings done, all taking care of their oral health, being on top of it. That patient, if they come to you for clearance, probably there's not much to do, and that patient can be cleared very easily. So that is from patient's perspective. Now let's look at from medical perspective. So from medical perspective, we have to think that first of all, where the patient is going to get radiation. First of all, whether it's radiation or bisphosphonate or denosumab, those are bone modifying agents. So what are we clearing them for? If it's radiation, our big concern is where the tumor is located and how much radiation will the patient get, and what effect will it have on the salivary glands in that area and the soft tissue in that area. So with radiation, that's the major concern that we have, and its impact, other impacts of radiation like trismus. And yes, we are getting better with radiation with IMRT, which is intensity modified radiation therapy. It's more focused, so less area uh, is going to get irradiated, but still it does have a lot of effect. Now, if somebody is getting bisphosphonate or denosumab, uh, they are still at risk of osteonecrosis. And these patients are basically at somewhat similar risk as radiation. And we have to educate the patients a lot in in both these cases. The reason being, the patients, it's hard for patient to process this information that they have been diagnosed with cancer and they have been told to see a dentist. So explaining that to them, that why we are doing this, and sometimes we have to make decisions which they won't like to hear. So explaining why this is for their own good, those things are very important. I would still say that if whenever I talk to oncologists, I told them to choose denosumab over bisphosphonate. The reason being, denosumab has shorter half-life, and so you can do actually surgical work after a small drug holiday, versus bisphosphonate has a very long half-life. What does it mean to your practice? So in your practice, it's a lot of liability issue. Can we still go wrong and do everything correctly, follow the procedure and still go wrong? Absolutely. But as long as we followed the correct protocol, we are fine. So types, there are different, I'm just discussing this briefly, different types of clearances: organ transplant, bone marrow transplant, joint replacement, chemotherapy, radiation, bisphosphonate. But radiation and bisphosphonate therapy is very different from the first four. The reason being is, even if somebody is getting an organ transplant or bone marrow transplant, joint replacement, and chemotherapy, they can still come and get surgical dental work without much risk after the fact, after they have got their treatment done. In radiation, you have the risk of osteonecrosis once patient has got radiation if we do surgical work. And one of the things in my experience, I have seen even patients getting osteoradionecrosis from SRP, something as simple as scaling and root planning, which we don't think much about. Uh, Bisphosphonate, denosumab, again, if it's IV, it's much more higher risk, but still at a lower risk than radiation. Dental evaluation should be performed with the bone marrow transplant as soon as possible after the diagnosis. I'll just go over everything real quickly. After the diagnosis, combination of disease and chemotherapy that can potentially lower the blood count. So think of this, why would somebody get a bone marrow transplant? So any of the diseases, most common that we see is multiple myeloma. And these patients, in most cases, have already been started on chemotherapy. When they get started on chemotherapy, the first thing that happens is their white blood cell count goes down. So checking that is very important. Uh, and making sure that we are in a range where we do not cause or start a new problem instead of taking care of the problem. If the white blood cell count is very low, you may need to pre-medicate the patient with antibiotic before we even do probing, because that also causes microbleeding. Usually, if that's the case, otherwise we can safely treat the patient. So one major concern, two major concerns with these patients would be checking the blood count, making sure patient is at a decent level with white blood cell count. The other concern is when the patient gets bone marrow transplant, they will be on high dose of immunosuppressants. So let's say we have a patient who has a tooth which has the potential of developing any kind of abscess or periodontal disease getting worse. Once they get the bone marrow transplant and they are put on these immunosuppressing agents, it will probably get worse. So we have to keep that in mind. So that means we have to be very aggressive with our treatment for these patients. Oral care. Very important. When I was working in the hospital a few years ago, we used to make rounds in the morning and evening on patients who are going through bone marrow transplant. And one of the things which we emphasized on for them is keeping their mouth clean, because they are immunocompromised at this point, and because of low WBC count, because of all the immunosuppressants they are getting, and they may develop mouth sores. Uh, but patients who have very good oral hygiene, it's very unlikely. So we have to be prepared for that. One of the things which we do a lot is recommend alcohol-free chlorhexidine for these patients to keep rinsing them out 2 to 3 times a day with that. Professional dental cleaning 1 to 2 weeks prior to being admitted to the hospital, making sure they have had a good cleaning done, emphasizing on oral hygiene. I also, apart from brushing and flossing, not just me, a lot of us do recommend water picks, which are very good for cleaning interdental spaces after the flossing. So again, you do not want to recommend the mouth rinse for very long period of time. So short period of time. And once everything has stabilized, patient can get off it. So post bone marrow transplant, basically one of the things which we can see is graft versus host disease. There is no cure for that, or palliative treatment along with management of inflammation. Normally, I recommend compounded medication for them. The combination is usually Maalox, Benadryl, and some lidocaine, which reduces the pain, and they are able to eat properly after that. Sometimes I would also try to add topical steroid in the combination, dexamethasone elixir, to see if I can get some inflammation down and control. Now, why is dental clearance so important for cancer patients? So radiation, chemotherapy, and more bone modifying agents cause damage to oral soft and hard tissues. And chemotherapy, it's very interesting the way it would work. Usually, the effects are very short duration and it's not very bad. In some patients, they may react badly to chemotherapy and they may develop severe mucositis. It's very rare. In 12 years, I've seen just one patient developing severe mucositis. Radiation, of course, has more. The other thing which can happen with chemotherapy is pigmentation, which is also very rare. Again, I have seen just one patient with pigmentation from chemotherapy, but radiation can cause immediate effect. With radiation, you can see ulcers developing, dry mouth right away, mucositis developing. So all these you can see. And of course, if we do surgical work on these patients, osteonecrosis can happen. If they are on more bone modifying agents, then medication related osteonecrosis of jaw can happen. But one of the challenges which is often gets ignored is oral dryness, because oral dryness can lead to multiple complications. If these patients, let's say they get radiation therapy and it affects major salivary glands where they are significantly dry now, they will have a higher tendency of developing cavities. So that means we have to make sure that we keep their mouth lubricated and we protect the teeth. The way we protect the teeth is recommending high fluoride toothpaste. And a number of these patients, if they are very dry, I would ask them to get the cleaning done every 3 months instead of 6 months. Another thing which I do is over-the-counter saliva stimulation products. It could be something as simple as sugar-free lozenges. which the patients can use. We can prescribe them medications like pilocarpine and cevimeline, but then we have to educate the patients that they do have side effects. With oral dryness also comes fungal infection. And most of the cases that I have seen of fungal infection in severe dryness are not the one which we typically look for, which is can be wiped off, is white, cheese-like. They are erythematous, that means red areas. Uh, you can do a swab or just start treating the patient with antifungal. And I already spoke about permanent damage that happens. So permanent damage is damage to the salivary glands. And with chemotherapy, the pigmentation, if somebody develops pigmentation, it's permanent. And some of these patients will fall into gray area. And I'll just talk a little bit about it. So have I done extractions on patients post radiation? Yes, but these patients have survived the cancer and has been post radiation over 7 to 8 years. And I still tell them the risk that they could develop osteoradionecrosis, but most of these patients have healed post extraction. The reason for this is gradually, once the effect of radiation starts weaning down, the process of angiogenesis starts. So they start getting the blood supply, and that's how the healing process gets going in the right direction. And one very important thing, unfortunately, I have seen the other side also. Patient who develop osteonecrosis, whether it's medication related or radiation related. And they can end up losing a part of the jaw or almost the entire jaw. I've seen extreme cases of that. So these patients could develop osteonecrosis either through dental work, or if they keep a bad oral hygiene or they are smokers and continue to smoke, they can develop spontaneous osteonecrosis. Uh, and this can impact their quality of life very severely. So again, here also patient education is very crucial. Let's look at oral complications. So 12% of the patients receiving adjunct chemotherapy will develop some sort of oral complication, and 100% of the patients receiving head and neck radiation, when doses exceed 40 gigs, they will develop some complication. Even if the complication is just dry mouth, they'll still develop it. Mucositis and other complications can be seen in cases of cancers of other region where patient is getting chemotherapy. So 12% of breast cancer patients, 33% non-Hodgkin's lymphoma, 70% in certain types of leukemia. And the reason it's high in leukemia is leukemia itself predisposes patients to oral complications and oral ulcerations, so that's why the risk increases. Oral mucositis is common complication of chemotherapy. It usually begins 5 to 10 days after initiation of chemotherapy. The good thing with this is it will go away once the chemotherapy stops. Most cases, it will go away. Let's see, effect of chemotherapy in oral cavity varies again from one individual. And even with radiation, I know it's very unusual to say this, but I see a lot of cancer patients. Almost every week I see them. And I've seen even with radiation patients, some patients will respond so differently from others, and which is very amazing. Why? And that explains a lot how our body reacts to certain things. And these problems are usually seen during treatment or shortly after treatment with chemotherapy. So painful mouth and gums, most cases then not, I would say that is this one, painful mouth and gums is because of low WBC. Dry mouth in this case would be temporary, altered taste would be temporary. That's why. Burning, peeling, and swelling of tongue, most cases it would be temporary. They can get infection very easily because of low WBC count. Christmas is something which is very rare. I have read in literature but never seen any single case from chemotherapy. So hemorrhagic mucositis is something you can see in chemotherapy. Pan-oral mucositis you can see in these patients secondary to cancer chemotherapy. Candidiasis secondary to cancer chemotherapy, and viral lesions. Because they are immunosuppressed, they can develop viral lesions. So bone modifying agent, and this picture is of a patient I saw, and this is a patient known who was known to me, and this is very, he was a colleague's mother, she was a colleague's mother, and this was a very interesting case. So she was, he told me that my colleague's mother-in-law, sorry, he told me that his mother-in-law has developed a red patch on the palate, on the tori. And initially, when somebody does that, the first thought that would come to my mind is trauma because there is a tori over there. And I said it could be tori. Then he came back to me in a couple of months that, you know what, it's not getting any better, doesn't seem to be trauma. And there's actually a very deep red area in that. So I've asked her to come over to the dental school and can you take a look? When I saw, my first question to her was, have you ever had been on bisphosphonates? And she said she just got off it about uh, 6 months ago, and she has been on bisphosphonate for over 7 years. And this is what I suspected, that is medication related osteonecrosis of the jaw. And we, of course, when we did the panoramic x-ray, it didn't show anything. So CBCT had to be done, and it did show the changes in the bone. And finally, the oral surgeon had to remove all of this. And the good part was she did heal well. Mostly, we'll see with bisphosphonate and denosumab, 94% cases have been described in patients receiving high doses of IV bisphosphonate. And that is very crucial to remember, that IV bisphosphonate is the main culprit. And it's substantially lower in somebody who has taken oral bisphosphonate, especially if somebody has taken oral bisphosphonate for less than 5 years. I'm not really very concerned, but I would still let the patient know and still document it that I had this discussion with the patient. And preference should be given to denosumab over bisphosphonate just because of short half-life, meaning patient can go on a drug holiday for 2 months and they will be safe to be treated surgically. When I say safe, you should still make the patient aware that there is still a risk, although it's very low. Then there are anti-angiogenic agents, antivascular endothelial growth factor for cancer treatment. These drugs are all these bevacizumab, sunitinib, malate, and sorafenib, all these. Then TKIs, which is axitinib and dasatinib and erlotinib. And these are all medications which can cause osteonecrosis, medication-related osteonecrosis of the jaw. And this is also an actual patient of mine. So in this clearance, I would basically all non-restorable teeth should be extracted prior to start of medication. And sometimes you have to explain to the patient. So this patient actually was never got the dental clearance, was started on bisphosphonate without seeing a dentist. And that sometimes happens because if the medical side is not aware of uh, what role we can play in helping this patient, they would not send the patient to us for clearance. And then he developed, the patient developed osteonecrosis of the jaw. And this patient, it was a very sad story because once we were done with this picture and examination, the entire part of entire thing, they just dropped on us. So this was all decayed bone, and they had open communication with their sinuses. So he needed, the patient needed surgical closure and everything. So, and this is why we should be very proactive with these patients. Important thing to note here is this did not happen because the patient had surgical work done. This happened because if you look at this patient probably had bad oral hygiene, and the tooth had most likely had secondary decay. I'll turn the light on a little bit. Tooth had secondary decay right here, and it was the combination of poor oral hygiene and secondary decay, probably some root decay, which triggered the osteonecrosis. My point here is it's not necessarily that the surgical work that we do that may trigger the osteonecrosis. It could just be spontaneous from bad oral hygiene, periodontal disease, or decayed teeth, and just plain infection. Any other surgical work like bone graft or implant should also be completed before we start patient on anything. Emphasize the significance of regular follow-up. Most of these patients, I'm very aggressive in recommending regular follow-up with their dentist. So with radiation problem during seen are osteoradionecrosis, permanent damage to salivary glands, oral fungal infection, which unfortunately can be recurrent in these patients because of oral dryness. Christmas, we are seeing less and less of these cases because of intensity modified radiation therapy, which is so focused. Mucositis, again, we are seeing much less than what we used to about a decade ago. Other infections can happen. Mucosal fibrosis may happen. I've seen mucosal fibrosis, but again, much less. Taste dysfunction is usually temporary and is associated with damage to salivary gland. Generalized decay, again, if this is a patient who's not following up a dentist or is non-compliant, are the ones who will develop generalized decay. Oral health related quality of life, of course, can be impacted severely. Challenges in maintaining oral hygiene. So that's another very challenging thing in maintaining oral hygiene. Few reasons for that. One is if they develop Christmas, it would be hard for them to brush. Second is, which I found, I'm doing a study on cancer clearance patients for past 5 years. I'll be publishing it next year. So there are interesting things that we came across during this study. So one big problem is when somebody is diagnosed with cancer, they already have a number of things to deal with and number of appointments. And between all this and all the treatments going on, uh, oral hygiene is something which easily gets neglected. And that's one of the things that can happen with these patients. Another other interesting things we came across is, of course, patient cannot afford the treatment, which is a big challenge. Communication, uh, no means of communication. So those things are big challenges for these patients. No, and again, when I'm educating the patients about why they are seeing me for clearance, I do show them pictures that what can happen from osteonecrosis of the jaw. And I do let them know that there is no predictable treatment or cure for osteonecrosis of the jaw, whether it's radiation related or medication related. The top one is an actual patient of mine. The second one is from a colleague. And my treatment, a typical treatment for osteonecrosis is pentoxifylline. Again, I'll clean up any decayed bone that I'll see over there very gently. I won't be very aggressive initially. And here you can see this bone looks pretty healthy when I look at the surface. So pentoxifylline, I also add low dose doxycycline. It could be 100 to 200 milligrams a day for a short period of time, and vitamin E also. There are studies which say they can help. Um, Debridement and surgery may be needed if it spreads, like it's spreading in this patient's case. So that you can see these bones are decayed. So they all need to be cut out and removed. This can become very bad, and patient may end up losing their job. So I do let them know. And you can see a pathological fracture here from osteonecrosis. And mucositis, again, this can be very common seen, but look at one thing inside the circle. This patient also has poor oral hygiene. And if we look at tongue, there is cobblestoning of tongue. We can see fissures all around. That means they are very dry. All these are contributing to the mucositis that we see. So for and a number of times these patients will say that I have not been brushing because it hurts, but it's like a vicious cycle. They have to keep their mouth very clean. And even if we have to numb them to give a local anesthetic and numb them to do the cleaning, we should do it. And this is just WHO oral toxicity scale about what is grade 1, grade 2. Normally, we don't see much of grade 4 anymore because of, not even grade 3 anymore because of IMRT. But we do see some grade 1s. Grade 1s are the most common that we see. Patients must be recommended to maintain oral hygiene regardless of. One thing which we found very useful for these patients is their sponge brushes, which are very soft and still are able to rub off the plaque film, and using alcohol-free chlorhexidine along with it. The reason I'm emphasizing so much on alcohol-free chlorhexidine is because alcohol in itself is an irritant for oral soft tissue. And I worked very closely with an ENT oncologist, and he used to say that although there is no scientific evidence, and this is a guy who was at one point among top 3 in US in ENT oncology, but he did believe very strongly that alcohol does contribute to head and neck cancer, alcohol related mouthwashes. They may not cause it, but they contribute to it and they probably make it worse. And in general, we know that alcohol containing mouthwash will burn more, especially if patient has mucositis. It will cause more pain to the patient. If any treatment needed, it should be initiated. So if we see any sign of mucositis, we should start treating patients. Big reason for that is because still they are in pain. Remember, after cancer therapy, the biggest concern of the oncologist is to get the patient back to their original weight and make them healthy. But if they have ulcers in the mouth and they are not able to eat well and they don't have a PEG tube, they will not be able to regain their weight and health. So radiation-induced mucositis has different treatment options. Nothing has been scientifically proven, but this is what US Food and Drug Administration recommends for treatment for radiation-induced oral mucositis. These are the medication, and my still go-to is, which I spoke to you in the beginning, and I do still believe in this, diphenhydramine, viscous lidocaine, xylocaine or lidocaine. So I would mix one of these two. I also mix Malox, and but recommending diclonine hydrochloride is also a good idea. Um, or I would mix corticosteroid along with this when I'm getting it compounded. That way, we are not giving too many instructions to the patient that you use this mouthwash, then you use this one. Instead, I choose to get diphenhydramine, viscous lidocaine, or xylocaine, and with Malox, and add dexamethasone elixir. Artificial saliva spray is over-the-counter agent frequently used to alleviate mucosal dryness in mild cases of radiation-induced mucositis. Treatment planning should be done by, like here, that's the recommendation. It may be different in Iran. Usually oral medicine specialists, even if the patient is directly sent to the oral surgeon, they'll send them back to us to make the treatment plan for these patients, or any dentist who has been formally trained in cancer clearance. So here we have another type of residency called GPR, which is hospital dentistry, and they are sometimes trained in cancer clearance. Then certain places have started, they have taken out a part of oral medicine and have started something called dental oncology fellowship. So they are also trained in it. A person who does the clearance should be able to manage post-treatment complications, and this is very important. If I'm doing the clearance, I should be able to manage any complications that's coming out from the treatment. They should be able to initiate measures to prevent severity of impact of radiation therapy on oral soft tissue, hard tissue. Now, this is something which I do. There is no literature in it, but since I've been doing this for a long period of time, I've tried it and it does work. So if I get a patient for radiation therapy and I've done all the work that is needed to clear them, and now I'm going to clear them and they're going to start radiation, that's when I talk to them about post-radiation care. So at this point, I would have a conversation with them. First, I would encourage them to see me once between the radiation therapy and then 1 week after radiation therapy. Then I would recommend them all the products needed for dry mouth. And I would tell them to start using the lozenges at least 1 to 2 days before they start the radiation therapy. What I have seen is that these patients usually do way better with oral dryness if they start the lozenges before the radiation therapy. If you ask me how that works or why that works, I don't have an answer at this point. It's just from my experience that I'm saying this. And the other thing is that I do tell them that if you see any ulcer at any point of your radiation therapy, I want you to contact me right away. The reason for that is you do not want it to get too worse or too bad before you actually see the patients. So a number of times I would also need help from temporomandibular disorder specialist and physical therapist. In those cases where I know the radiation is going to be very close to the temporomandibular joint, then I'm worrying about two things: its effect on the joint itself and the muscles adjacent to the joint. Whereas if it's somewhere away from the joint, I'm just worried about the muscle. And usually TMD specialists would recommend them, or the physical therapist would recommend them exercises like opening and closing their jaws multiple times after each dose of radiation, and making sure they keep moving their jaws around in all directions and exercising them, and sometimes massaging them in different ways. So getting them on board is a good idea if possible. Otherwise, you can give instructions to them yourselves about making sure that they exercise their joints. All non-restorable, borderline. So this is how I explain to the patient. Because if I get a patient and I tell them, hey, I'm taking out 14 teeth, that will be a shock to them. So I go over, show them picture of osteonecrosis, then I tell them that this tooth may be looking excellent, good today, not excellent, good today, but I anticipate that it will cause problems in next 5 years, where it may need to be taken out. Any tooth that may need to be taken out in next 5 years, because I'm basing on 5 years survival, expected survival in most cancer, they should be taken out. Restorative work, if the radiation oncologist insists that we need to clear the patient quickly, small restorative work can be done as the radiation therapy is going on or due after the radiation. If they need root canal, they are willing to save the teeth and need a root canal, I would not do it myself. I would send the patient to an endodontist or a dentist who is very well experienced in doing root canals and who can be predictable. So, because you do not want that root canal to fail. If it fails, you may get into the situation of doing extraction. So the whole purpose of doing the clearance will be gone. If implant supported denture is planned, implant should be placed prior to radiation therapy by experienced provider. Again, this is a high risk thing because osteointegration of implant can take up to 3 months. So can we afford to delay patients' cancer treatment for 3 months? I'm not sure. Again, doing this, uh, if we plan to take this route, we have to make sure that the oncologists are okay with it. Because in some cases, rare cases, they may not be planning radiation very quickly. So they may say, yeah, it's fine, let's go ahead and do that. Something which I have done way back about, I would say, 8, 9 years ago, placed mini implants because mini implants heal very well. And I placed 3 on both sides, so 6 on lower and 6 on upper. And then we planned implant supported denture. Of course, with that, there is a lot of controversy. Lots of periodontists would not agree that mini implant is a good option. Uh, Here, I'll argue that even though it's not the best of option, but for cancer patients, we are just hanging on to things, and whatever we can do, we can try to do. If we end up placing implants or mini implants, we have to make sure because of the metallic component, we cover it, have a plan to cover it up during radiation therapy because it will get heated, come in contact with the soft tissue, and that can cause ulcerations. So this is a case of 62-year-old male patient, was referred for radiation clearance, stage 3, T3N1M0 of major salivary glands. So that means I knew that the tumor was in parotid. Patient's surgical part of treatment was completed, and he already had the parotid gland removed. And he could not tell me his dental history. So he said he knows his teeth are in bad shape, and the last time he saw a dentist was most likely for extractions. Now that's always a bad history. He also informed that that's what he was done. And here's his history: hypertension, diabetes, right parotid, infratemporal fossa tumor, which was, of course, removed. And these are the medications. So not very complex medical history. And this is his actual X-ray. Now, my concern is in a patient like this, if this was a patient who was very high dental IQ and very educated patient, I would probably try to save at least 2 to 3 teeth in the lower quadrant to make a lower partial, just because lower arch does not support a complete denture very well without implants, and retention can be issue, and then make a upper complete. But this was a patient who was very challenging. Who was very challenging, and even like something which I haven't put in the presentation. First time he came for extractions, he brought his relative with him, and he decided he doesn't want to get it done, and he completely disappeared on me. So I called and informed the oncologist that this is what's going on. The oncologist spoke with him, and then he finally came. So in his case, I ended up planning a full mouth extraction because I knew he would not follow up. And then these teeth, which I was thinking of trying to save, will start decaying the way these have decayed. Or you can see expansion of lamina dura here, severe bone loss, both horizontal and vertical in most areas. So here is where you have to, the treatment plan was based on patient, more so on patient than anything else. And my reason of trying to save these teeth was, think of it that patient is getting radiation in the parotid region. So the scatter radiation here would be low, but still it would still, because the parotid is already removed, his salivary flow was already affected. That means he was still high risk for getting cavities. That means if he doesn't follow proper oral hygiene, even if I leave these 6 teeth, he will end up having cavities in them and needing extractions. So unfortunately, that's how I had to base my decision on. So I just spoke about a study. So this was prepared a year ago. So that's why it's 3 years. Next year, it will be 5 years. Actually, this is the 4th year that this project is going on. And these are the problems we found: challenges, no insurance, patient cannot pay, or limitation in insurance. So in US, even if somebody gets dental insurance, there is a ceiling beyond which they won't pay. And we found the need for combining medical and dental insurance because these patients are getting these dental work because of their medical needs. Available funding limited to patients meeting means assessment. So this is something specific to US. If they don't meet the means assessment, that means extra funding that they may end up getting for their dental work. They won't qualify. Means if they are not poor enough, they won't qualify for these fundings for treatment. Lack of patient compliance is a big thing. Lack of understanding. Dental phobia is very common. Misinformation. So very common question that we get is, if I have a tooth taken out, it will reduce my eyesight. So you have to re-educate the patient on that. Concerns regarding appearance and diet, which is very genuine concern, and you have to let them know, hey, we understand that, but this is something necessary. And concern regarding follow-up dental care, which is actually a good problem to have. A number of my patients will say, hey, you're taking these teeth out and I'll have this much remaining. I'll still need more teeth to chew. What will happen after my treatment? So we say, hey, we have a plan in place and we'll complete your treatment when you come back after after your cancer treatment. And these are the things, choosing between alveoloplasty and alveolectomy. So alveoloplasty refers to shaping of alveolar process. We all know that using surgical. Alveolectomy means surgical removal of bone for prosthetic purpose. And let me explain this to you, why this is so crucial. So when we are doing extractions for dental clearance, for radiation therapy, what you don't want is those patients not healing in time for radiation therapy because there was a sharp bone remaining, or the patient's wound did not heal soon enough. So just taking a burr and making a flat top, just smoothing. I'm not saying reducing way too much, but reducing and making a flat top like a tabletop on the table on top, making sure that the bone is nice and smooth on the top can help accelerate healing, and patient won't have complications later on. Also, lots of irrigation to make sure there are no bony spicules remaining. So that is very crucial. All surgical work should ideally have predictable outcome. I just spoke about it. Giving clearance with inflammation present after surgery can end up delaying cancer treatment. I may have it, yes. So if we are doing clearing the patient before cancer treatment for head and neck cancer, we may end up delaying cancer treatment because for patients to get radiation therapy, they have to be fitted with a mask, and I'll run a video to show that. And if there is inflammation anywhere in the face and they have fitted the mask has to fit accurately to the face anatomy so that the patient can remain still during radiation therapy. If they are not still, the radiation would not be able to target the tumor. So if there is inflammation and we clear the patient and the mask is fitted during inflammation, when the inflammation is gone, the mask will be loose. And then the patient can move their head around inside the mask. And that will cause the radiation to fail. So they will end up delaying the radiation. So I hope you all are able to see this. So this is kind of plastic which becomes soft when it's soaked in warm water. They are just waiting for temperature to cool down a little bit before they fit, and you can see how it's fitted completely. This is done by radiation technologist. So it has to adapt perfectly well. And then they'll let it cool down. Once it becomes cool, it will become hard. So this is once it gets fitted during radiation therapy, this is how the patient is going to be. So it gets locked so that the patient cannot move their head around, and that way they are able to target the tumor properly without worrying about missing it. And this is how the dosimetry chart is with IMRT. So here, and normally when I'm doing the clearance, the radiation oncologist would send this to me. So here they are saying this area will get 70 gigs of radiation. This area will get 40 gigs of radiation. This area, 60 gigs. So I'm worried about all these except this one. And that's why it's so important, knowing how much scatter radiation patient is getting. Proton therapy, which is being debated, I attended an oncology conference a couple of months ago, uh, and but it's still very controversial. I spoke with another radiation oncologist here. He does not agree that it's a very good at this stage. It can only target certain types of tumors, which are solid tumors, and not every type of tumor. So you have to be like, this is something which I threw in, but uh, this is not something which I anticipate we are going to see a lot in next 5 years. Who benefits? So basically only solid tumors with very clear borders. And it's very difficult to find cancers with defined and clear borders. Um, and cancer that has not spread to other parts of the body. So there are too many conditions to it. Radiation patients should follow up after radiation therapy to complete the remaining treatment. Again, when I'm doing this, I do, apart from telling them to follow up, I do recommend document all those things, because even if they come back, I may forget by the time they're back to see me that what my plan was, what instructions I gave. Any further treatment for mucositis or trismus should be initiated soon. Saliva stimulation should start the day radiation starts, or ideally, I would say at this point, 1 or 2 days before. Patient should be recommended follow up with dentist, hygienist every 3 months. And this was a 74-year-old female patient, 3 years post-surgery radiation chemotherapy with squamous cell carcinoma of base of tongue. Cleared by local dentists for radiation and chemotherapy without providing patient any education. Patient now has 3 anterior retained roots and abscess tooth number 30. And the dentist refused to see her. Now, what these are the cases I'm giving as an example. Now, what this puts us in a very bad situation. If we leave the retained roots and abscess, let's see how many things can happen. With abscess on number 30, which is a lower right um, first molar. If we leave that abscess on number 30, this patient, if we start with something simple, may end up developing Ludwig's angina, because we cannot put the patient on antibiotic forever. If we don't take the teeth out and drain the abscess, they may still develop osteoradionecrosis. And if we do that, they may still develop osteoradionecrosis. So either way, we are in a very bad situation with this patient. What I ended up doing is educating patient, explaining to them that this is the scenario, and taking a good consent that, hey, she's aware that when I take the tooth out and drain the abscess, the patient may still develop osteoradionecrosis. And then I took the tooth out, drained the abscess, put her on antibiotics for, I think, if I remember correctly, 14 days. And anti-inflammatory agents, I followed her every in between and then towards the end. Fortunately, she did heal. But that does not mean I was sure that the patient would heal. I was on my toes through all this time. I was worried about the outcome. So it can be a hit and miss. There is no predictable uh, treatment at this point in a situation like this. 72-year-old patient diagnosed with aggressive squamous cell carcinoma of maxillary alveolar ridge extending to hard palate. And this is the ENT oncologist I used to work with. And I assisted in the surgery in the OR with this patient. Surgery was done, partial maxilla was taken out. In these cases, I recommend that this was a situation where this could not have been done. But in an ideal situation, if a patient has squamous cell carcinoma of maxillary alveolar ridge, at this point, they should see a prosthodontist and get an impression of a good impression of upper and lower jaw, so that when they have the maxillectomy done and there is a clear communication between the mouth and nasal cavity, they are able to get an obturator to close that, because although the surgery can be done with a flap taken from either upper arm or thigh or chest, that graft may not always be successful. And that's exactly what happened in this patient. The graft failed, and the patient needed an obturator to close the communication. And I ended up doing this. This was the communication. I apologize, the quality of picture is not very good. This was my initial impression, and taking the initial impression was a challenge because we didn't have an impression. So part of the alginate went into the nasal cavity and we had to take it out. Once I had the initial impression, I was able to make the special tray. And fortunately, at this point, I was not worried about the material going in. And I made the final impression with the special tray. And this is what the obturator looked like. So this closed the communication. Plus, it also worked as a partial for her missing teeth. So, and she could speak properly, eat properly, and everything went well with this patient. And this is again very interesting case. I'm trying to basically not read and explain to you. So patient was referred to the clinic for discomfort in the teeth and to improve the quality of life. And this was post-cancer treatment and had a history of oropharyngeal cancer with surgery, radiation, chemotherapy, and renal cancer with treatment with chemotherapy only. And according to referral note, the initial cancer was in tonsil. So this was a patient who was developing multiple cancers. Then there was recurrence at some point at which it spread to the tongue base and pharyngeal area, which needed lateral neck dissection. In this surgery, he had pharyngectomy, tongue base resection, and mandilectomy, and a reconstruction, soft tissue flap, all on left side. And the surgery was done at University of Kentucky. Left mandible was missing. They had to remove everything beyond lower left second premolar, and the entire ramus is missing. Only the condyle head and small portion of neck remain. He continues to be on G tube, the feeding tube. And patient was not aware of the amount of radiation. And this patient never had a proper dental clearance. And this was his medical history: AFib, hypertension, mitral valve regurgitation, diabetes, cancer, hypercholesterolemia, iron deficiency anemia, and these were the medication. And they had a number of remaining teeth, but they were all at different stages of either decay or generalized bone loss. That means there were not enough teeth that could be saved. And he had a bridge on lower right side, and some of the teeth have crowns. and he's not able to eat properly, and there is discomfort. And this is how he looked like. And this is this is a patient. I cannot give you a good way of managing this patient, because what we are seeing is a complete mess. So this could have been planned way better. And this teeth actually had some pus coming out, some purulence. We never leave a third molar, which is restored before clearing. So this patient was never sent to a dentist. And then once the complications started, they were referred to us to help him out. And pretty much what we could do at this point was do palliative care. So we sectioned the bridge. We did take this tooth out. We left this one. And if you look at this crown, it's a really bad crown. Look at the overhang here. And this one also had overhang. And then you can see all the roots here. So like I learned, this patient didn't survive much after that, but till he was alive, basically, we were doing infection control and pain management on this patient. We could not do much on the patient. And a lot of this, to my understanding of what I understand about clearance, could have been avoided if the patient was sent to a dentist prior to starting the radiation or the surgery. Thank you. Any questions?
Okay. Uh, Dr. Hassan, thank you very much for your interesting lecture. It was very informative and precise. Dear audience, if you have any question, please let me know. We have some question.
Sure.
First of all, would you please let me know which antibiotic is more effective in patients suffering from post-radiation osteonecrosis following tooth extraction?
So it's not antibiotic, it's one antibiotic. Sorry, I misspoke. But the main medication is pentoxifylline. And the antibiotic that I give along with it is doxycycline, which is low dose. It's usually about 100 to 200 milligrams a day. If I'm giving 200 milligrams, I would split it, one in the morning, one in the evening. But main medication would be pentoxifylline.
Okay.
And the other thing which I add is vitamin E.
Okay, the other question is that what has been your experience with hyperbaric oxygen?
So this is very controversial. Again, there is literature and we have done it. I won't say we have never done it. We have done hyperbaric oxygen uh, for patients who are post-radiation and then needing extraction, and we don't have a choice. But usually the oncologists, they don't like it. It has, and on patients where we have done the hyperbaric oxygen, it has worked. Patient did not develop osteonecrosis. So yes, but I would also add that making sure that the oncologist is okay with it is very important. Any other question? For completely preventing muco. No, I have not, and we are seeing less and less of mucositis happening with intensity modulated radiation therapy. So we have not seen too much of mucositis. And again, my experience with has been with the palliative care combination of lidocaine, um, diphenhydramine, and Malox, and maybe adding dexamethasone. That's my go-to. Clindamycin has become very controversial recently because of the increased number of cases and evidence about clindamycin causing pseudomembranous colitis. So it's not a drug of choice anymore in the US. The FDA basically took off the recommendation for use of clindamycin unless there's no other option. So now if we use amoxicillin, and we have to use something else if patients are allergic to amoxicillin, we'll go to erythromycin group. Laser, no, we have not used laser for any mucositis. We do not recommend placing implants that soon after radiation therapy, uh, big, and we have never done it. The only surgical things that we have done post radiation has been at least 5 years over radiation and extraction. So no, we have not done. Thanks for your kind words, all of you. Any other question? Thank you. Thanks for having.
Another question is that would you name more treatment in patients with oral dryness after radiation?
Sure. And I'll address one more I'm saying about use of topical. Yes, I do. So we do recommend topical fluoride as well as high fluoride toothpaste. I even recommend, like post-radiation patient, I would tell them to make a thin tray, like a bleaching tray, and put topical fluoride in it and wear it for 10 to 15 minutes and then brush it. So that is it's very, very good. And it works very well in, say, preventing cavities. And yes, so few things which I recommend is, of course, over the counter, if we are going topical, over the counter saliva stimulants like sprays, mouthwashes, sugar-free lozenges. And one of the things which I recommend is, sorry, it's allergy season. So one of the things which I recommend a lot is cool mist humidifier. Cool mist humidifier, keeping next to the patient's bed at nighttime, or even if they're sitting for long duration somewhere, helps lubricate the mouth. You have to let the patient know that it won't work right away. It will take a few days before it starts helping them. A few days to weeks. They will eventually start feeling moisture in the mouth as well as their nose and oropharynx. Because the other thing with dryness is the oropharynx dries up and they can start changing their voice. So that can be prevented as well. And if that does not work, if patient is still able to produce some saliva, then putting them on medication like pilocarpine and cevimeline is a good choice. We have No, we do not, like here completely, it's contraindicated to do any surgery, alveolar surgery for years after radiation therapy. So we do not do it. Dentures, you can basically do once the radiation is complete and the oral soft tissue does not appear angry or friable, you can start making dentures. As long as we don't do any surgery and we make sure the mouth is lubricated, denture can be done. Normally, after radiation, I wait 3 months for denture to start working on dentures.
Okay. Okay. Thank you very much, Dr. Hassan.
Thanks.
Thank you very
so
much.
much for having me. I enjoyed it. And if you have any questions, feel free to reach out to me anytime.
Okay, thanks a lot. Your lecture was very informative and interesting, and thanks for accepting our invitation. I hope we will be your host in Iran as soon as possible, and the certificate.
Yeah, I look forward to it.
Yes, it's our pleasure. We will be happy to see you in Iran as soon. And
sure, thank you.
You're welcome. And there is a certificate for your participation and for your lecture. I will email it for you. Thanks a lot.
Sure, thank you. And no, I'm basing a lot on, not on experience, but on literature and recommendation and guidelines. So there is a cancer society here, and I'm basing all the recommendation on their guidelines about surgery. Okay. Thank you.
Okay, thanks a lot, and goodbye. Have a good time.
Thank you, you too.